why don't we talk about, if you will, the classic patients? I mean, putting aside those patients with normal ejection fractions, the patients who have heart failure with reduced ejection fraction. Now, not being a cardiologist, I wasn't aware that you guys call this HFrEF.
We do.
Heart failure, reduced ejection fraction. I like HFrEF.
Yeah.
It's easier to say. But what proportion of heart failure with reduced ejection fraction, what proportion of that is that of the entire heart failure population?
It's about 50%. So
It's a lot.
You know, it depends on which survey you look at, but overall, we consider heart failure with reduced ejection fraction an ejection fraction that is less than or equal to 40%.
So 40% is your
40% is our cutoff.
Okay.
Above that, we call it either heart failure with preserved ejection fraction. Now, the Europeans have made a new category. They're calling it heart failure with mid-range ejection fraction, and that's really just to confuse us all. But we've traditionally called anything below 40 or 40 and below HFrEF, and anything above 40 HFpEF, heart failure with preserved ejection fraction.
Just to save words.
Just to save words.
The main distinction, though, is because these are arbitrary cutoffs. The main distinction is that there is no evidence-based therapy that has yet been proven to work in patients with heart failure with preserved ejection fraction, whereas we have a whole armamentarium of therapies in patients with heart failure and reduced ejection.
So it's going to be fruitful to drill down on these HFrEF patients,
Yes.
the reduced ejection fraction patients. So let's establish, again, right at the outset, who are we talking about? What are the characteristic patients with HFrEF?
They're patients that have multiple comorbid conditions. So there are patients, up to 2/3 of them will have coronary heart disease. A lot of them, up to 40%, may have diabetes or atrial fibrillation. Many of them have long-standing hypertension. So they have risk factors and concomitant diseases that go along with heart failure and may increase the risk of getting heart failure.
So these are kind of the classic patients, right? The patients with peripheral vascular disease, other evidence for vascular injury going forward. These are the ones you look at the Netter diagram about when you were in medical school.
The important thing to remember about HFrEF is that these are patients who have an abnormality of cardiac contraction for a whole host of reasons. Some of them have it because they had heart attacks. Some of them have long-standing hypertension. Some of them have genetic cardiomyopathies. Some of them have left bundle branch block, which leads to an electrical dysynchrony that can make their heart worse. But at the end of the day, their heart doesn't pump as well as it should. And that's really the primary problem. And it causes a lot of other things to happen, like a neurohormonal cascade that is secondary to that. But the primary problem is the lack of contractile function.
And I think that in that way, heart failure with reduced ejection fraction is kind of the final common pathway for a lot of different illnesses, right? So that over time, Don Lloyd-Jones and others have made this point that the lifetime risk of developing heart failure is about 20% for most people, independent of the age at which you start. And it's largely because if you're lucky enough to survive your heart attack, then down the road you might develop heart failure.
Okay, but again, I didn't miss that in the middle of your sentence. If you're lucky enough to survive your heart attack. So post-MI is one category of folks who have a problem with this. You don't need an MI to have this.
No. I think Scott listed a number of different things that are there. Hypertension is a big driver, and I think, as Orly pointed out, control of blood pressure is a critical feature of trying to prevent heart failure development.
What do these folks look like when they come into your office? I mean, in medical school, I was taught heart failure, you squish when you walk, and you pant, and you don't breathe very well. What do you look like? What do these HFrEF folks look like?
Well, if you think about what is heart failure, I mean, I like a definition that says that heart failure is the inability of the heart to provide enough cardiac output to the body, or to do so only at the expense of elevated filling pressures. Now, what does that mean? Elevated filling pressures means that you have congestion. If the left side of the heart can't function as well as it should, that blood is going to back up into the lungs. And then it's going to keep backing up into the periphery as well. And so congestion is one of the primary things that we see in these patients. That is, they have shortness of breath. They can even have pulmonary edema, of course. They can have right-sided edema, including swollen ankles, early satiety, and so forth. Their neck veins are elevated. In addition, if they're not providing enough cardiac output, they can be tired. They can not be able to do the things that they want to do. And you have to be able to ask the patients, what can you really do? If you say, how do you feel, they may say, fine. But if you say, can you make your bed? No, I can't do that without feeling short of breath.